Good morning, everyone, and a great opportunity. I'm so glad to be here to introduce and kick off our key session of the day on a foundational topic in potentials of AI in medicine, particularly in diagnosis. So I'm Jonathan Chen. I'm an assistant professor in biomedical informatics research in Stanford and also a practicing internal medicine physician. And before I came into medicine, I was a software developer and I got a PhD in computer science. And I imagined medicine would be this very logical, deductive application of decision-making, but instead find that there's a lot of somewhat best guesses, very educated guesses, but somewhat arbitrariness to the way we have to practice because of so much uncertainty. So it's no surprise then for 30, 40 years that particularly diagnosis has been a foundational area for AI applications, but has really been shown to emerge much greater potentials with the advancing technologies we're going to hear about in this session, and many kind of imaging applications in ways that could only have been imagined in years prior. Right? Many of the things we can learn through AI tools, they might not be able to do specific recommendations of treatments and things to really understand the causal natures and mechanisms of disease. It really requires this nuance of expert intuition. But what it can be very powerful for are understanding correlations, predictive ability, and that's all about assigning labels of things, which is exactly what diagnosis is. Arguably, there's a lot more to medicine than just making a diagnosis. We have to know, I often know what's going on with the patient. The harder question is like, what do I do about it? Nonetheless, there's this foundational need. Everything depends on making that right call at the beginning. Otherwise, everything downstream will be problematic. And that's why there's this own epidemic of diagnostic errors that almost everybody will face at least once in their lifetime, and which we often aren't getting the right feedback and don't have the right tools. And as smart as we are as individuals, to make it scalable and consistent for the whole population, we need the kind of tools that are being developed and deployed by the speakers we're hearing from today. So to narrow that down a little bit further, very glad to introduce our first speaker, Dr. Jeanne Shen. She's an assistant professor of pathology, associate director for the Stanford Center for Artificial Intelligence in Medical Imaging. And she's going to tell us more about a key opportunity of growth in terms of AI-augmented pathology. Right, these are the doctors, the ones who take out samples of your body and look under a microscope and try to make sense of what they're seeing, and can describe to us more about the challenges and opportunities. Dr. Shen, if you could take it away.
Thanks for the kind intro, Jonathan, and the opportunity to share my perspective on some of the most pressing needs and challenges in the area of pathology that I think AI could potentially help address. So to start off, I wanted to show this figure from a recent paper, which looks at trends in the number of healthcare-related machine and deep learning studies on PubMed. And you can see that there's been an exponential growth in the number of studies being published, which is not surprising. But what was surprising to me is that when you look at the breakdown by medical specialty, pathology actually right here, the biggest circle, is now the #1 most published specialty in medical AI, even surpassing specialties such as radiology, which have been developing and deploying AI models for far longer. So what sort of accounts for this seemingly sudden interest in pathology in AI? When I meet people outside of medicine and I tell them that I'm a pathologist, one of the common reactions I get is, oh, cool, so do you do autopsies like those people on CSI? And in fact, no. Most of our patients are still alive, and even though we don't usually interact with them directly, we're far more involved in their care than you might think. Oftentimes, we're the ones making the final diagnosis on any patient where a tissue or a fluid specimen is collected. And when a patient undergoes surgery for cancer, for example, we evaluate the completeness of resection of the cancer. When a patient receives treatment before their surgery, we also evaluate the response to the treatment. And now, particularly in the era of precision medicine, we're increasingly responsible for determining which ancillary biomarker tests should be performed to determine the patient's expected prognosis or their response to a particular treatment, which then guides how the patient is treated downstream. We also interpret the results of many of these ancillary tests that we order. For example, on the right-hand side, you see an example of PD-L1, which is an immunohistochemical biomarker that's scored by pathologists and which predicts in some cancer types whether the patient is likely to respond to immune checkpoint inhibitor therapy. And so when we look at the status of our specialty in 2021, we continue to play a critical role in diagnosis, but because of our responsibility in selecting and interpreting biomarker tests, we're now playing an increasingly important role in guiding patient management as well. And at the same time, the volume of cases that we're expected to review per day continues to increase, while the number of things that we need to report on continues to increase as well. For example, this is what a pathology report for esophageal cancer looked like in 1995. And you can see it's really quite concise. And now this is what an equivalent path report looks like in 2021. So you can see that not only is it a lot longer with a lot more elements to be reported, but we also have a lot of ancillary biomarker results that are being reported here, in addition to additional studies such as cytogenetic studies with fluorescence in situ hybridization, shown here. And so now in 2021, when you add to the fact that pathology is kind of an aging specialty in that more older pathologists are retiring, while not enough younger pathologists are being trained to meet the demands of the increased case volume and complexity, there's a relative pathologist shortage that's projected to only get worse in the coming years. And so all of these factors account for the increasing interest in applying AI to pathology. It's a way of addressing these issues. The last factor, which I think accounts for the growing interest in pathology AI, is the adoption of digital pathology, which has particularly been spurred by the COVID pandemic and the need to work from home. And this has resulted in an increase in the amount of data that's available in the form of digital whole slide images for model development and validation. Because it takes a significant investment for a lab to go digital, there is also an increasing need now to demonstrate a return on investment for digital pathology. And a significant part of this ROI, I think, is expected to be in the form of new AI models for making the diagnostic process more accurate and more efficient from both a time and cost perspective. So what are the most pressing needs that AI can assist us with? Well, most of the currently available or in development applications seek to address one of the following two general need categories. The first one I refer to as first-generation histomorphology, which focuses on assisting pathologists with tasks that they already perform quite well. For example, by making diagnoses more accurate, either by helping us reach a final diagnosis on a challenging case prospectively, or by acting as, for example, a double-check tool after the prospective diagnosis has been rendered already to catch any diagnostic errors or misses that might have occurred. Such models can also help increase diagnostic efficiency by reducing the amount of time needed to reach a diagnosis, or they can contribute to cost savings by helping the pathologist reach a final diagnosis without needing to order unnecessary ancillary tests. Assistance with case triage and prioritization is also a task that AI can help with, which might allow cases with the most critical findings, for example, to be reviewed first, or which might selectively exclude low pretest probability specimens from downstream ancillary testing. So an example of a first-generation histomorphology application would be AI-assisted Helicobacter pylori diagnosis on routine H&E stained gastric biopsies. To provide some brief context, H. pylori is the most prevalent chronic bacterial infection worldwide. There are over 4 billion individuals affected, and it's a well-known cause of peptic ulcer disease, gastric cancer, and many other pathologies. If we can identify infection and eradicate it through medical treatment, this reduces the risk of progression to those downstream complications. And so every single gastric biopsy that we get in the pathology lab is evaluated for H. pylori. And all you need to do is find one convincing organism to call the biopsy positive. The problem is that you're essentially searching in a large surface area like this for a tiny organism that looks like this. And this process can sometimes be really time-consuming and tedious, not to mention that misdiagnoses are not uncommon. There are ancillary stains that can be done to look for H. pylori, but these add additional cost and turnaround time to the diagnostic process and are not necessary in most cases. And so we developed a deep learning model for automatically diagnosing H. pylori on these routine H&E stained gastric biopsies. And this was work done in collaboration with Andrew Ng's lab and co-authored by two grad students, Sharon Zhou and Henrik Markland. And here you can see an example of the whole slide image viewing interface showing the model's output probabilities, p equals, in the image, along with a bounding box around the corresponding region in the image, which allows the pathologist to skip right to the highest probability regions to make that diagnosis that this case is positive or negative for H. pylori almost instantly without having to hunt around in this huge surface area here. And this is just one example of some of the many tedious manual tasks in pathology that are really ripe for AI-based automation, such as hunting for other rare findings like metastatic cancer in lymph nodes, for example. The second area where I think AI can really help augment pathology is next-generation histomorphology, which is sometimes referred to as histomics or molecular morphometry. So the central dogma of molecular biology is that DNA gets transcribed into RNA, which is then translated into proteins, which then affect particular biological functions, which then sort of are manifested in the characteristic histomorphologic phenotypes that are visible under the microscope. And so the premise behind next-generation histomorphology is that by directly analyzing the histomorphologic phenotype, we can either infer downstream clinical outcomes, such as whether a patient's tumor is likely to recur, or infer the status of specific upstream events, such as the presence or absence of a clinically actionable mutation in tumor, which might then be predictive of downstream response to a particular targeted therapy. And so, in essence, AI-based next-generation histomorphology mines whole slide images for subvisual features that the human eye can't detect or quantify very well, with the goal of either identifying novel image-based biomarkers, which might be predictive of patient outcomes, or replacing current biomarker tests, which are often expensive and add significant turnaround time to diagnosis. Replacing them with these equivalently performing image-based biomarkers that can be run directly on routine H&E whole slide images. And so an example of a next-generation histomorphology application would be a model, for example, for predicting the risk of recurrence of hepatocellular carcinoma after surgical resection. And this was work shown here that was done in collaboration with Daniel Rubin's lab and first authored by Rikiya Yamashita, a postdoc in the lab. So there's a huge value proposition for AI-based biomarkers because overdiagnosis and overtreatment are such big problems, particularly in oncology, because current biomarkers are not that accurate in many cases at predicting who might respond to a particular treatment. So there's a very low threshold for treating patients, which results in overtreatment and an increased risk of treatment-related toxicity and additional healthcare costs also related to treatment. So to summarize, first generation and next generation histomorphology are two areas that are really ripe for AI augmentation, and we're seeing a lot of activity right now in these areas. However, there are three major challenges that need to be overcome in order to convert the promise of AI for pathology into a reality, and these can be conceptualized into the following three categories, which are data, generalizability, and implementation. The first two challenges, data and generalizability, go hand in hand. So we're currently limited by a lack of interoperability due to vendor proprietary whole slide image formats and platforms for deploying these models. And even though there's now a DICOM standard available for whole slide imaging, it hasn't been widely adopted. We also know that there's a lot of variability in the histologic slide preparation itself, and differences in quality, for example, in the intensity of staining between different pathology labs. And we know that models that are trained on one whole slide image format from a particular vendor, or whole slide images that were digitized, prepared and digitized in a specific lab, do not perform equivalently when they're run on whole slide images from a different lab or that were scanned on a different scanner model. In addition to that, it's really challenging trying to get reliable ground truth annotations for data. Because it's so labor intensive and generally requires some degree of pathology expertise, which is really expensive. And also in some cases because the gold standard label might be ambiguous, especially when you're dealing with challenging diagnoses with lots of inter-observer variability in the interpretation. And then lastly, the potential for biased data sets to result in biased models is a widely acknowledged challenge right now. And we've seen this, for example, with models being trained on image data from racially homogeneous patient populations that are then unable to generalize well on images from patients of a different race. So then the third challenge is implementation. How do we optimally integrate a specific model into the clinical workflow? So in the case of that AI-based H. pylori diagnosis model that we showed, it had a very good model performance with an AUC of about 0.96. But when we tested its impact on pathologists in a simulated clinical workflow, we found that it significantly improved accuracy and turnaround time on the positive cases, but it significantly reduced the accuracy and turnaround time and increased turnaround time on negative cases, which led overall to a decrease in the accuracy and no net change in turnaround time. Then other issues that need to be addressed, which are not adequately being addressed right now, are model explainability and trust or mistrust of model results, which can really impact how well the pathologist or the end user interacts with the model and consequently what the actual impact of the model is. Then there are issues with automation bias and then these additional challenges with medical legal implications and regulatory barriers. And so coming back full circle to the beginning, the goal of this session was to elaborate on the role of AI in diagnostic excellence. And when we think about what diagnostic excellence entails, not just in pathology, but across all medical specialties, it means making the right diagnosis in as cost-efficient and timely a manner as possible, while delivering added value through the integration and delivery of prognostic and predictive data that can then be used directly to guide downstream patient management. While there's a lot of work being done in AI to address these needs, there's much less work being done to address some of the other current challenges and barriers to progress in the field. So to summarize then, I think the opportunities for AI augmentation fall into these two general need areas. First, in next-gen histomorphology, but that three major challenges remain to be overcome: data generalizability and implementation. There is work being done to address these challenges, and I think that these actually represent really great opportunities for us to concentrate our attention on in the future. So with that, I will end here and say thanks very much to the audience for your participation, and also to the AIMI Center for the invitation to speak today, and to my collaborators that I've had the opportunity to work with on some of the projects you saw.
Thank you, Dr. Shen, for that great discussion. A lot of things we can learn from that. And but let's kind of keep the discussion going. Moving on to now applications in cardiology, multimodal data sets. Dr. David Ouyang, one of my good friends who I've worked with for many years. He's a cardiologist and now a researcher in the Division of Artificial Intelligence and Medicine at Cedars-Sinai Medical Center, a physician scientist. He's got a lot of great applications in deep learning, computer vision, and statistical analysis of large data sets within the cardiovascular space. A lot of really impressive work in echocardiograms, for example. He's going to tell us more specifically about that work. So Dr. Ouyang, go ahead and tell us more about diagnostic accuracy and precision medicine and cardiovascular phenotyping. Looking forward to hearing from you. Take it away.
Well, thank you so much for this opportunity to be here this morning and share with you guys some of my thoughts regarding AI and improving clinical excellence. Really appreciate Kurt, Matt, Nigam, and everyone at the AIMI Center for their generosity, their collaborativeness, and their excitement to really be cross-disciplinary across radiology, medicine, dermatology, pathology, and really kind of pushing AI forward. The title of my talk is Improving Clinical Precision with Artificial Intelligence. For this talk, I'll focus on what does clinical variation mean, particularly in cardiology and cardiovascular imaging. What are ways that we can improve it, particularly for two main approaches, which is assessing cardiac function and assessing cardiac hypertrophy. My disclosures are below. I kind of have some consulting with Anthem, Ultramics, and I have funding from the NHLBI. First, in clinical medicine, people disagree. Whether it's in the clinical setting, for example, on the left, we're seeing this news report in which a cardiologist is disagreeing with a nephrologist or a kidney doctor, and then they actually get into a physical altercation. Or in clinical imaging, it's very common for like-minded, meaningful, thoughtful clinical experts to disagree what is the right treatment, what is the right diagnosis, and what is the right way to take care of patients. On the right, we see that this is true especially for imaging, because imaging is a place where we're making predictions, we're prognosticating, we're identifying things before it's entirely certain, and we have that written down in the record. So it's easy to go back and say, was that correct or incorrect, or do we agree with that assessment? This tweet on the right-hand side really shows that the more you know about the imaging, the more you want to read it yourself. It's describing that in this article published in JACE, the Journal of the American Society of Echocardiography, when cardiologists look at echo reports, they often want to look at the underlying information, because this is an understanding that there is inherent variability across providers, across readers, and across interpreters. That means that they want to get to the ground truth and they want to understand what's really going on. This is an opportunity for artificial intelligence to be particularly helpful, because this is an opportunity where, with the right models, with the right algorithms, we can decrease clinical variance to the degree that maybe people can trust reports enough where they don't have to look at the underlying ground truth or the underlying imaging. An example of how clinicians change or affect the interpretation is particularly true in echocardiography in the assessment of ejection fraction. The ejection fraction is the ratio of the heart's size at end systole and diastole as a metric of how much it changes in size, how much cardiac output is going, and is incredibly important in assessment of many different diagnoses and clinical management. Particularly in cardio-oncology, this might stop important chemo drugs. This might allow us to recommend ICDs or defibrillators, and this also drastically changes the medical regimen in terms of what therapies one should be on. Despite its importance, what we see is that there is inherent human variation. On the top, there's the distribution of what the end systolic and the end diastolic volumes are. You can see that this is actually fairly smooth across the range. It's very physiologic, meaning that there are bigger patients, there are smaller patients, there's a broad range. And even though the ejection fraction is a ratio of these two numbers, we see on the bottom is that this actually has much more heterogeneity and much more bias. This is true because a lot of those thresholds are incredibly important. The threshold of 35 indicates whether we should put it in a defibrillator or not. The threshold of 50 or 55 indicates whether someone has heart failure or not. Oftentimes, because the clinician is called upon to make that judgment, we're seeing that there's a little bit of hedging, that numbers ending in 0 or in 5 are outsized representation in this histogram, because people don't want to make the call, or people are really at the edge and uncertain about what it means. If there's additional clinical accuracy and additional clinical precision, there's an opportunity to influence care, an opportunity to actually be more precise and allow for better management. So my vision, and a lot of what I imagine many of the audience agrees, is that machine learning offers the opportunity for precise phenotyping. And this has both prognostic and diagnostic utility. And by precise phenotyping, what I mean is that we can both measure things more frequently and measure things more precisely. If we have a good calculator, and abstracting it out, whether it's AI or an actual calculator, the more precise we can do it, the more frequently we can do it, the better it is for a patient. Last year, we published a paper in which we created a deep learning model to assess ejection fraction. We show that because the standard of care is to measure just 1 or 2 frames of a video, a deep learning approach allows us, one, to measure every frame of the video, allows us a more beat-to-beat assessment that can be more granular and more precise. And two, that when we do it more frequently, it ends up being a more precise measurement. I don't want to belabor the point for this assessment, but this shows that a deep learning approach, particularly when trained on thousands or tens of thousands of examples, allows the opportunity to create measurements both more frequently and more precisely. In this setting, we compare with humans. We show that our precision or our variation is less than human-to-human variation, and that this is particularly striking in the settings when it's pronounced. In atrial fibrillation or in places where the heart rate is very variable, the ejection fraction can change beat to beat. But the standard of care or the traditional clinical practice is to just measure 1 beat. If we can measure multiple beats, this allows for more precise measurements and better care of patients. A second opportunity to identify and find ways to be more precise and change clinical management is the phenotyping of rare diseases. When in the clinical practice, we're looking at tens, hundreds of images every day, human attention is fatigable. It's easy to miss something that only happens 1% of the time, or even kind of 0.1% of the time. However, often these rare diseases are places where we can make the biggest impact in terms of medical therapy and in terms of management of patients. So in a paper that we're currently assessing, we actually automate the process of measuring left ventricular hypertrophy, the different wall thicknesses, and adjudicate whether it's high or low likelihood for common types of hypertrophy, including cardiac amyloidosis and hypertrophic cardiomyopathy. On the right-hand side is human clinical variance. If you had a report today and then had the same study 2 or 3 weeks from now, how much variation is there across that clinical experience? Because humans don't necessarily measure the same frames or don't necessarily measure the same way each time. And on the left-hand side is actually EchoNet LVH, our model to assess this in an automated fashion and its performance across 3 different centers at Cedars, at Stanford, as well as in the United Kingdom through a Unity data set of 9 different hospital centers, but primarily Imperial College, London. In this setting, you can see that variation from study to study or from human to kind of AI shows that there's more precision and it's allowed to actually be more precise if you automate this process. Humans aren't necessarily any better at measuring a distance from pixel A to pixel B than in the automated approach. But by doing this in a deep learning fashion, by doing this across multiple frames and multiple heartbeats, we can come up with a more precise, reproducible measurement than having an individual do it once across a study. By doing this, we allow for precision phenotyping because, again, human attention is very fatigable. We might recognize that we're not very precise with doing this, but even then, we might not necessarily be confident in making a downstream diagnosis of things like cardiac amyloidosis. But this allows the model to integrate this information of both hypertrophy as well as features we don't yet understand, whether how bright the walls are or how much contrast there is or how thick the myocardium is in different areas, and create with a deep learning approach to identify things like hypertrophic cardiomyopathy and cardiac amyloidosis. Ultimately, screening is something that humans have a challenge or find challenging because it's an incredibly laborious, tedious, and low relative ratio task that ends up being often the perfect place for automation and the perfect place for artificial intelligence. I wanted to thank everyone for the invitation and looking forward to kind of the discussion and answering questions.
Thank you so much for that, Dr. Ouyang. I'm looking forward to discussing more of this. But to kind of get additional perspective, I'd like to move on to Dr. Nina Kottler. She's got over 15 years of experience as a practicing radiologist, as well as graduate training in applied math and optimization theory. Even more impressive, she's the Associate Chief Medical Officer for Clinical AI and serving on Radiology Partners Innovation Steering Committee, leading their data science and analytics division in the clinical value team. Notably, in 2018, she received a Trailblazer Award, recognizing a pioneering female leader in the field of imaging informatics. Dr. Kottler, looking so forward to hearing more about your discussion on how AI is going to drive value in radiology and beyond. Thank you, and take it away.
Hello, everyone, and thank you for having me. My name is Nina Kottler. I am a physician, a radiologist, and I'm also the Associate Chief Medical Officer for Artificial Intelligence for Radiology Partners. And today I'm going to be talking to you about AI in radiology, and more specifically, we are going to be speaking about the role of AI in diagnostic excellence. Here are my disclosures. All right, so let's get started. So if we're going to be spending time talking about diagnostic excellence, it's really important for us to understand why. What is important? Why do we strive for diagnostic excellence? And certainly as humans, we want to master a subject. Maybe you have a personal value or of excellence, but what underlies a lot of that? And what underlies a lot of that for many of us is that we want to improve outcomes. For patients that have pathology or diseases, we want to decrease their morbidity and mortality. For patients that haven't developed a disease, we want to prevent it. But is that enough? It is an important part of the quadruple aim, improving outcomes, but there's other components as well. And we're at a place right now where our healthcare system cannot afford additional cost. So we can't improve outcomes at any cost. In fact, we have to improve outcomes at a same cost or even better, a decreased cost. And what that means is we've got to use value. We've got to drive value. Now, value in its very simplistic form is quality or improved outcomes divided by cost. And the only way that I know to really do both, improve the outcome and also decrease the cost, is using artificial intelligence. And so today we're going to talk about how AI drives value and diagnostic excellence, but also value on its own. So how is AI used right now in radiology? If you split radiology up into the different components, everywhere from the minute that a referring clinician orders an exam, all the way through the acquisition and reconstruction, interpretation, follow-up, and peer learning, every single component of this can be optimized with artificial intelligence, and it is already. There are algorithms being used in every single segment of what I call the imaging life cycle. And many of them are even FDA cleared. The most common of these is CAD-T. And that's what we're going to talk about today. How is this as a use case, CAD for triage, how does it drive diagnostic excellence? Now, what is CAD-T? CAD-T is a triage algorithm. So it's essentially an image detection. It uses computer vision to detect a finding, a pathologic finding, usually a critical finding. And then it connects with our work list to alert the work list and move that study higher so that the turnaround time of the exam and the interpretation of the exam is quicker. So what does that look like? If this is your work list, it would alert the work list to a pathologic finding, and that may be on a stat study, but it also might be on a routine exam or an inpatient exam. And then hopefully your work list will be able to change the order based on the priority of the pathology. And with that, it should be able to drive improvements in outcomes, right? You get to the study faster, the patient is treated faster, it should improve patient outcomes. But you could also downplay its use. And that's why I wanted to talk about CAD-T specifically in how it drives value, because many of us read our stat studies within 30 minutes. Does it really matter if we read the study in 20 minutes or 30 or 10 minutes instead of 15? And frankly, while it can make a big difference for our outpatient imaging exams that we may not get to for a day or even more, how much pathology and these critical findings are we really seeing on those outpatient imaging exams? So you could downplay the value of CAD-T, which is why I wanted to talk about it. In fact, that was something that I thought. And until we actually ran a trial, we ran a 6-month pilot using a CAD-T product, actually 2 CAD-T products. And we found some interesting findings, and I want to talk about 2 of those with you today. Okay, so there's 2 additional ways that we found in this pilot that AI, specifically CAD triage, can improve or drive diagnostic excellence. So the first way. So CAD-T, a triage product, made us more accurate. Now, this wasn't something that we thought of that would happen initially, right? It's just supposed to move a study up on the work list. You're supposed to read it faster or get to the study faster, but we actually found it also made us more accurate. For pulmonary embolism triage, there were 4.4% of cases that we were otherwise missing. For intracranial hemorrhage, 2.4% of cases that we were missing. Now, we know we're human, right? We miss things with the AI. AI also missed things, but we do know that radiologists plus AI together is better than either one alone. And so we were able to detect more findings. Clearly improvement in diagnostic excellence. The question you should be asking now is it really improving patient outcomes? So 2 examples of actual missed cases are at the bottom of this slide. And the one on the right-hand side is a small PE, and it was an isolated PE. The one on the left, the radiologist, right? The one on the right-hand side of the slide is a really subtle subdural hematoma. It's almost so subtle, it's really hard to see at these window levels next to the calvarium. And frankly, we found a lot of findings were these subtle, isolated cases. So that brings up the appropriate question. If we find these cases, are we actually improving patient outcomes? Are we driving value? You could think of a scenario where you put all of these patients with these really tiny intracranial hemorrhages into the hospital. You may be just increasing cost without actually driving value. Or if you treat all of these small, many of them which were subsegmental isolated pulmonary emboli, does that treatment actually benefit the patient? Or do you get more complications than you get benefit? So the big question is, can you maybe ignore these subtle findings? Is it okay that we're missing them? Well, anecdotally, we already have evidence that no, subtle findings cannot be dismissed. So here is a 72-year-old patient that came in with altered mental status. The initial study was read as chronic changes, but the AI algorithm found a really subtle subdural hematoma. And we alerted the emergency department about it. They called the patient back. And when the patient came back, they came back about 36 hours later between imaging time. And this is how their study appeared. Significant increase in the size of the intracranial hemorrhage. It covered the entire left cranial hemisphere. It was big enough that even with the volume loss that the patient had being 72, there was significant mass effect on the brain, compressing the left lateral ventricle, causing left to right midline shift. In fact, this patient needed to have a decompression surgery with craniotomy. So just because we see a subtle finding or AI is helping us detect a subtle finding, doesn't mean that it is insignificant. Some of these really do affect patient outcomes. And hopefully over time, as we get more of these, we'll be able to tell which patients this should happen to, and that we should tell the ED, hey, listen, you have to treat or at least admit these patients, and which ones are probably safe enough to go home. Okay, the second component what was really about peer learning. And remember, we missed some studies, and we thought it was really important for all of the exams that we were missing to be evaluated and coalesced and looking for learning lessons. And those learning lessons, we went back and worked with our radiologists in order to help them improve their diagnostic excellence. And it was a great program. And what I want to talk about today is how we can see that expanding over time. Right now, all of our AI is really a narrow detection. It's usually for one finding, but we're starting to see algorithms that have many more findings, and we can use them as a way for continued learning. So let me give an example using chest X-ray. So chest X-ray, the error rate, the published error rate is anywhere up to, in some places, 40%. So let me use a 20% error rate to give an example. So here we have 190 chest X-rays. If you have a 20% error rate, you're going to find 38 hidden errors within these chest X-rays. Okay, some may be big, many are probably small, but there's 38 of them. So what happens if we use traditional peer review? Can we find those? Do we learn from them? And if you do 3% random peer review, well, that's 6 cases that are going to be reviewed by peer review. What does that look like? Okay, 1, 2, 3, 4, 5, 6. One of them statistically will overlap with one of the learning events. So out of the 38 chest X-ray errors, with 3% peer review, you get 1 learning lesson. And actually, that learning lesson may be dismissed. And there's definite data that shows that people don't like to peer review cases where there's an error. So that could be even 0 learning lessons. Now, what if you do 5% case review? Okay, 5% case review, you're just doubling the number. So 38 chest X-ray errors. In this case, you learn from 2 of them at most. Well, what if you use AI for this? Now, there's already AI vendors out there that are looking at 9, 40, even 124 different findings on a chest X-ray. What if you use that as a mechanism of peer learning? The AI can review 100% of the cases. The specificity is not perfect, right? So let's say the specificity is 95%. That's around the accuracy that we tend to see. Usually it's a little bit higher. what kind of learning lessons can we get in this example? So let's go back to our 190 chest x-rays. We've got 38 chest x-ray errors. If you apply an AI algorithm looking at all of them with a 95% sensitivity, you are going to catch 36 of those cases. And that's a significant improvement in terms of learning lessons. Think about the teaching cases and teaching files we can create. Think about how much more quickly we can educate our radiologists to be better and improve their diagnostic excellence. All right, but we're not talking just about diagnostic excellence, right? We were talking about value. We can't have diagnostic excellence at any cost. So the question is, does CAD-T decrease cost? Now, cost on its own is difficult to measure in the hospital. It's very complicated. However, we do have a couple of proxies to evaluate cost, and they are length of stay and ED throughput. Those are two of the more common ones that our hospital clients look at when they're trying to determine how much money they're spending. And so here is some literature that I have coalesced from different groups. Okay, two of them are from Cedars-Sinai and another two from Yale. And they have found, yes, that CAD-T, two triage algorithms, have actually decreased the length of stay, and a significant decrease, whether it's intracranial hemorrhage or PE, in days, and ED throughput measured in almost 1 hour. And now there's more work that needs to be done to show, does that actually decrease cost? But the suggestion is yes, right? We're certainly moving in the right direction. We know right now that CAD-T has improved diagnostic quality. We think it also significantly has the opportunity to improve outcomes. And with this, it also decreased lengths of stay and increases in ED throughput. And hence, hopefully, it will be decreasing cost. So what did we talk about today? We talked about the goal of diagnostic excellence, and improving it is really to help improve patient outcomes. We talked about 3 different ways that CAD-T can improve our diagnostic excellence: faster time to treatment, accuracy improvement, so we're missing less things, and then using it as a source for continuous learning. And then finally, we talked about how CAD-T decreases length of stay and increases throughput, which hopefully in the end will decrease cost. I do believe that this is just an example of the most common AI algorithm out there, but I think this idea is applicable to other AI, and I'm really excited for our future because I strongly believe that AI will drive value, not only in our practice of radiology, but in healthcare overall. Thank you very much.
Great discussion, Dr. Kottler. Looking forward to continuing discussion in the panel. Our last key speaker for this session, looking forward to hearing from Dr. Walter Wiggins. He's a practicing neuroradiologist. He's got clinical interest in spinal, oncologic, and vascular neuroimaging, but also, importantly, he's the clinical director of the Duke Center for AI and Radiology, doing a lot of great work establishing infrastructure and procedures for translating all these machine learning technologies into clinical practice. Really looking forward to hearing him discuss his particular interests, monitoring clinical deployments and education in this dynamic field. Dr. Wiggins, please take it away.
Hi, I'm Walter Wiggins, the clinical director for the Duke Center for AI and Radiology and neuroradiologist at Duke University Medical Center. And my talk is going to focus on some of the problems facing clinical implementation of diagnostic AI tools and how we can maintain our standard of diagnostic excellence through Vigilance. I have no disclosures. So one of the biggest problems facing clinical deployment of AI is generalizability. This is a well-known problem where a model trained on data from one institution or even a couple of institutions may not perform well elsewhere. This was nicely highlighted by a study out of Mount Sinai where they looked at generalization performance of a deep learning model for pneumonia detection on chest radiographs and found that it didn't perform as well at other institutions. This has also been outlined in machine learning tools for detection and prediction of sepsis in clinical data. The group out of University of Michigan recently published a study on their experience with a sepsis prediction model operating on EHR data. And some of the key issues they outlined in the paper itself and in a nice tweet thread from Karandeep Singh is that the definition of sepsis used by the model was different from the standards used in other studies and the standards used in University of Michigan itself. Also, there was an issue with respect to the transparency of model coefficients, meaning that they didn't have a clear understanding of all the predictors that were going into the machine learning model. And then finally, the outcome variable definitions were very important in understanding the performance and understanding what the intended use of the sepsis tool was versus what their outcome variables that they were interested in were. This all brings up the question of external validation of AI, so testing on data from other institutions, populations, and/or geographic locations. There's an increasing emphasis on the importance of this in academia and certainly in the ML industry more broadly. But unfortunately, as I understand it, at least, it's not strictly required by the FDA at this point. They do expect clinical validation of tools prior to providing FDA clearance by the 510K pathway, but there's not a strict requirement as to the number of institutions or the geographic variability in their explicit guidelines. So there are some concerns out in the community regarding AI performance, particularly for imaging. These tweets highlight some of the concerns from a neuroradiologist who uses this tool in his practice, where an FDA-cleared AI algorithm for detection of intracranial hemorrhage on head CTs actually had some pretty significant misses. And so again, this highlights some of the concerns regarding AI performance and generalizability to other institutions. So how do we analyze performance and try to get a sense of how these algorithms perform from institution to institution? Well, one way of doing this is, and some vendors do supply this, is NLP of radiology reports, or processing the reports to extract some sort of ground truth as to what the actual diagnosis is, and then comparing that versus the model prediction and flagging those discrepant cases for review. So looking at a confusion matrix, comparing the actual versus the predicted result, we would focus on these off-diagonal cases for quality assurance and failure analysis. And these are areas where the model and the interpreting physician disagree. The University of Wisconsin has published a couple of nice studies in the past year on this, looking at detection algorithms for intracranial hemorrhage on head CT and cervical spine fracture. So again, their focus here was on the discrepant cases where the AI algorithm disagreed with the radiologist's prediction, or rather the other way around, and also looking at cervical spine fractures as well. And what's interesting about these studies is with cervical spine fractures, in most failures, they were able to identify either a specific pathology, particularly with false positives. They were able to identify anatomic variations or other pathologies that may have been throwing off the algorithms. But unfortunately, in the intracranial hemorrhage detection, they were unable to find good reasons for some failures, where they even went so far as to analyze the texture of images with a technique called CT radiomics, and weren't able to determine any significant differences between cases that were predicted positive and were truly positive and those that were false negatives. So this brings up the question of how are we going to explain these algorithms, and do we need to explain these algorithms? And so some of the techniques for explainable AI certainly have some limitations. We look at this heat map for classifying chest radiograph versus abdominal radiograph, and using the CAM technique, we get one pattern. Using the grad CAM technique, we get a completely different pattern. And so while these images are intended to highlight the pixels that were deemed important by the algorithm or had significant weight in the penultimate layers of the algorithm, we really don't know what exactly it is that the AI technique is doing here. And these tools can only give us some clue and may even provide some false reassurance as to what the algorithm is thinking. So there was a nice blog post recently highlighting some points from a discussion with AIMI co-director Nigam Shah, talking about the different types of AI interpretability, and that the type needed may vary depending on the context and depending on the use case, but that each type of interpretability, from causal interpretability, why the input produced the output, to the engineer's interpretability, how the AI model produced the output, to the trust-inducing interpretability, where as you know, we look at the performance of the algorithm and say whether or not we're agreeing with the algorithm because of its past performance. So there are some types of bias that we can encounter in AI as well. First of all, there's the radiologist bias, in that we may be susceptible to automation bias in the form of anchoring bias, where we anchor to the model's prediction, or confirmation bias, where we're looking for things in the image to try to confirm what the model has already predicted or what we already suspect. Then there's model bias. Models can be biased by age and gender, demographics, and scanner variables. And so what are some solutions to these problems? Well, for the radiologist, it's very important for them to review the imaging study before they look at the AI results whenever possible. And for model bias, this is a problem that's best solved during training or retraining when we make sure that there's adequate representation of these different factors within the training data. There's a nice study out of Marzia Ghassemi's group looking at how AI can bias radiologists and other non-radiologist physicians, where they took advice that was reported to either come from AI or humans and measured the effect of that advice, whether it was accurate or inaccurate, and found that inaccurate advice could certainly bias radiologists and non-radiologist physicians interpreting chest radiographs and decrease their diagnostic performance. And it didn't matter whether that advice was reported to come from a human or reported to come from AI. So this all tells you that we need to be able to monitor AI in practice. And we know that the performance may degrade over time. So how do we monitor and when do we intervene? This is a timely discussion. There was a recent letter to the New England Journal of Medicine by Sam Finlayson and colleagues outlining various sources of data set shift and potential methods for monitoring and mitigation strategies that I'd encourage you to give a read when you have a chance. So how do we think about AI governance and monitoring at Duke? Well, first of all, we think about how do we test products or models that we've developed locally prior to implementation. And one important component here is shadow deployment, whereby we run the model in the background and analyze its performance before ever deploying it clinically. So this is important for gathering baseline statistics for ongoing monitoring, but also for understanding how well an externally developed model generalizes to data at Duke. And it can also be important to have a test or research UI for canary deployment. And then one other consideration is if we're purchasing a model from a marketplace, we talk to our vendor and see if there's a way that we can test the model before buying in completely and subscribing. So when we're using these tools, it's really important to understand their limitations. At Duke, we use an AI tool for multiple sclerosis plaque detection and quantification that actually does perform really well for supratentorial lesions, that is, lesions that are in the cerebrum or upper part of the brain. But unfortunately, it's not great for infratentorial lesions. And we've tried working with our vendor to improve the sensitivity of this model for the infratentorial lesions by optimizing our protocols and by optimizing the parameters that we can adjust with respect to this model. But unfortunately, we just haven't been able to make a lot of progress on these infratentorial lesions. So interpreting these studies, we need to keep that in mind. Another important consideration is algorithm quality assurance. We had an incident recently where new scanners and protocols fooled our dementia AI tool. So we're getting results like this, where we should be seeing the cortex in the temporal lobes here highlighted with red coloration of the pixels and the subcortical white matter highlighted with white. But unfortunately, due to changes in protocols with new scanners implemented at various sites across our system, we found that there was a significant underperformance on certain studies. And the result was that there were these reports being issued to the referring clinicians who were trying to manage these patients, showing an estimation of temporal lobe atrophy, which can be seen in temporal lobe dementia syndrome, such as Alzheimer's disease. So we were getting inaccurate quantifications of temporal gray matter volume that were affecting the clinical interpretation of these studies. So we had to work with our vendor to optimize our imaging protocols to get better results. So what else is needed in practice? We need systems for semi-automated monitoring. We can't always rely on humans. We need to monitor performance, data set shift for demographics, technical factors, distribution of diagnoses. Take-home points here, clinician in the loop remains critical no matter whether you're using imaging AI or EHR data AI. We need to train our end users on ML tool use and quality assurance. We need to understand the limitations of these models. And we need to work with our vendors to try to implement solutions and improve problems before they become pervasive. Thank you for your time.
Fantastic, Dr. Wiggins. Such great discussion and such a privilege now to be on with all our panelists. We have a great stream of questions coming in and a lot of rich things we should get into. So I'd rather just dive into it. Let's talk about some of the provocative things that come up. There's so much potential, there's all those things you can imagine, but also appropriate discussion like, whoa, there's a lot of challenges we got to face. We're actually going to get there. So I'll just start going through some of them. Daniel Carranza, this question will be for Dr. Shen, but anyone can jump in thereafter. Ask a question about what are your recommendations for reliable AI system pathology? You pointed out, what's the gold standard? Sometimes 6 pathologists can't even agree on the diagnosis, let alone the stage of the disease. I mean, what is the AI system even supposed to learn in that case? And how can you, perhaps Robert Lab says, can you have some kind of objective assessment through computational technology? And will people even accept that? What's your approach to thinking through such issues? Okay, I think you're muted.
I forgot to unmute myself. I think it depends on what your definition of reliable AI is, right? I mean, if you're thinking about the ground truth, then I think Daniel's absolutely right that sometimes there really is no reliable gold standard besides consensus from experts, right? So I think that's a difficult question to answer. I'm not sure if any of the other panelists really would want to weigh in on this, but yeah, I think in that setting, all you can go by is, consensus, right, from people who you trust.
That makes sense. Yeah, any other panelists want to jump in? It looks like Dr. Kottler, maybe you're unmuting, sir, if you want to take a shot.
Yeah, it might be a little easier in radiology because we can use another study. So if you are looking at a chest x-ray and you want to know if a pneumothorax is there, or if a nodule is there, you could have the comparison of the chest CT, which is going to be a higher spatial resolution, higher quality, and use that as the source of ground truth rather than experts. We do tend for things like mammography and knowing if it's a malignant lesion or not, we tend to trust the pathologist. So that's, again, the ground truth is going to be the consensus of experts, but it's helpful when you either have another exam or a group of people that are doing it.
Great to see. Dr. Ouyang, do you want to make a comment? Then we'll go to Dr. Wiggins. We'll just round back.
Yeah, I would say that I think what the point is incredibly important, that there is significant clinical heterogeneity, whether we can use kind of an additional kind of ground truth as a more reliable metric. The framework I would say is that that's actually made me think about the tasks that we want AI to do. As you can see, that kind of going from classification tasks, especially tasks where we're not even sure if humans can do, can be fraught with danger and risk. Whereas as we go down to simpler tasks, things like segmentation or measurement, we can invariably see whether we agree with that segmentation or not, becomes just easier and a little bit more standardized.
Actually, I'm going to come to Dr. Wiggins in a second, but I wonder if it's a challenge if we can connect it more longitudinally. Sometimes the ultimate patient outcome is maybe the ultimate arbiter of what the gold standards are in some sense of what things should be, tying things back. That's really what this is all about, but nonetheless, the challenge is there. Dr. Wiggins, can I have you comment? You kind of alluded to it. Daniel also asked a question about continually learning systems. You talked about some measures Duke is doing to kind of monitor and evaluate them. How do you think the FDA or somebody should regulate these things? You're going to approve, yep, this system works well, let's, approve that one. But the whole virtue is that they can continue to adapt and learn. But that means it's this moving object. This is a really hard question, so I don't expect an easy answer. But what's your perspective on how we can think about it, at least?
Yeah, so I think that the AI and ML industry more broadly is moving in that direction for this idea of continuous learning and trying to monitor for drops in performance and intervene accordingly. I think we should be doing that too in healthcare. The problem is that with commercially available algorithms, those are subject to the guidelines put forth by the FDA. And while there was some draft guidance last year that got into this concept of the total product life cycle, I think there's been some distraction from the COVID-19 pandemic, and that really hasn't gotten pushed forward in a substantial way. So I think we're still in this position of having to basically resubmit for FDA clearance every time we make a substantial update to a particular algorithm. But for locally developed algorithms, we certainly can play around with this concept of continuous learning and trying to measure the drop in performance over time, come up with automated or semi-automated methods for doing that, and then consider what the best approach is for either retraining or training the model from scratch or fine-tuning the model going forward.
Great, thanks. I got another real great lowball question for you or anyone else wants to jump in. Tim McLaren actually had the most popular questions, really about kind of disparities, let alone bias in terms of, the Ivory Towers versus just a community hospital who's trying to make do. I mean, what you described there, I think makes sense, and have some additional monitoring and interventions. But that's, like Duke can probably do that. Maybe Stanford can probably do that. We have specially trained experts in data science teams. The clinical practitioners in a typical community setting, they're not going to be able to do that, right? So what's realistic, or is it just going to be all the academic centers? The rich are going to get richer, and the poor, sorry, are going to be left behind. How can we develop and distribute AI systems that actually benefit everyone rather than the privileged few? Now, the easy question, maybe I'll pass it to, I saw David just unmute. Let me let you get the comment and we'll come back.
Yeah, I was going to say, I think that there's many different opinions about kind of what the FDA is doing and what's the best way to go forward. James Zhao and I and a couple of others, kind of Roxana and Eric and Kevin Wu, recently wrote a paper in Nature Medicine where we're looking at kind of, if we look at how FDA approvals of AI technologies are currently happening, the vast majority are single-centered. The vast majority are retrospective, and we're really not using the full threshold or the high standard that we put to other medical interventions for AI. I would actually advocate that we still need more RCTs, randomized controlled trials. We still need to fully understand how humans interact with new technologies. And rather than lowering the bar, we need to improve or increase that bar, because ultimately, Dr. Chen, like you're saying, many places aren't equipped to fully validate these algorithms. It's really the onus is on the FDA to really adjudicate that this is safe and really kind of more rigorously determine that this is a fair and reasonable product before allowing it on the marketplace.
Great.
I can comment on that as well. Yeah, the FDA, it's really interesting because these are machine learning algorithms. So you would think that the FDA is clearing a machine learning algorithm, that it's able to learn over time. It's actually not. What the FDA is clearing is a machine learning algorithm that is frozen at one point in time. And so if you want that machine learning algorithm to improve, well, that's not going to be FDA cleared. You're going to need to recertify it. The FDA does have a program where they're called pre-certification, where they're trying to figure out, how do we do that? How do we make sure that these algorithms can learn over time and that we can clear it? And so what they're looking at is not clearing the algorithm itself, but actually clearing the vendor, looking at the vendor's processes for quality and how they monitor those to make sure that what the vendor is doing is appropriate. And I think that ties into the original question, right? Because the original question is, how do you make sure that even a community hospital or a practicing radiologist working by him or herself is able to manage this? And I think it's going to require some work on the side of two areas. One, we're going to need some more regulation from the FDA. And two, I think that there's going to have to be more work that's done by the vendors and some of our societies to make sure that these algorithms are stable over time. Now, again, they're frozen at a point of time, so the algorithm is going to be stable, but your data may change. We want to, I think you talked about this already, right? Data changed at Duke, and suddenly the algorithm didn't perform as well. So how do we make sure that those mechanisms are in place to monitor that? We're going to have some more work done by the vendors and by our societies to make sure that everyone can benefit from these great tools.
Yeah, and I just gave a talk at a CME course last week that was predominantly private practice radiologists talking about what they need to be asking of their vendors when they're looking at purchasing these AI algorithms. And exactly the kinds of things you mentioned, where we need to look to the vendors to help us in developing some semi-automated tools so that it's not just places like Duke and Stanford and Rad Partners that are able to do this type of monitoring and assess for drops in performance, but really anybody out there who's using these tools should have access to, by their vendors, some sort of procedure for monitoring the performance over time.
And I just have one last comment about it, because I think this is such an interesting topic. A lot of the work that we do to make sure that our algorithms are staying at high quality is after the fact. Right? It's the RAD might notice, oh, this didn't work really well. Let me submit a sort of quality review back on this one case. But what we really want to be doing is prospective evaluation. We want to be looking at our data a priori to see how it's going to be changing. And some of the AI vendors have the ability to do this. They can assess a study as it comes in and say, well, have I validated my algorithm on studies that look like this? And if it hasn't, maybe they should be sending that back or sending the information to the radiologist, because ultimately the radiologist needs to be we're accountable for the results, and we need to understand them.
Fantastic. A lot of rich discussion we'll get to. We've just got, I think, a couple minutes left to go. I want to round back briefly to Dr. Shen. It's actually Jacob Matura made a comment, kind of aside. I'm a nuclear medicine doctor. How come there's not more nuclear medicine doctors here? Really want to tell us to, it was interesting. I didn't realize you pointed out that pathology is actually the leading field in publication in this area right now. I did not know that. So why do you think that is, and where does that tell us in terms of where the potential is for the future, in terms of what are the areas that are going to be more ripe and more able to integrate these types of technologies better than others, and why do you think that is?
So I think, again, it goes back to the huge role of pathology in rendering the final diagnosis, even though we're not completely reliable sometimes.
When pathology can't tell you the answer, you're in trouble, because where do you go to next?
Right. Patient outcomes, I think, certainly, as David had mentioned, that's the ultimate arbiter, I think, of whether or not an AI model is going to be clinically useful. But going back to why I think pathology is so popular now, it's a new field, right? We're a little bit behind radiology in terms of data, but I think people see the promise, especially for precision medicine. And right now, I think obviously people follow the money. I shouldn't say this, but I think there's a lot of money, especially in oncology, and there's a lot of unanswered questions, regarding patient management, like who's going to respond to a particular, let's say, drug, right, chemotherapy drug. And so I think right now, because, looking at the tissue itself is the closest that we can get to the biology, right, or the phenotype. I think that is a major reason why pathology is so hot right now. When you look at the literature, I think over 50% of the literature is cancer-related literature in pathology.
Fantastic. I think we're just about out of time to take a break. So much rich discussion we have, but hopefully we can re-engage afterwards in one format or the other's topics on how come there's all these COVID models, but they didn't seem to make a difference. I think it's a lot of this implementation people are bringing up. How do you address different discrete entities? Where do people get training? How do you do all these different elements of ML ops? How do we study things beyond images? And I think a lot of rich discussion. So let's continue this discussion in other forums, and glad to take a break now. Fantastic discussion. Look forward to seeing everyone in the panel and the audience in the future.